possible. Remember that Dr. Ratner is sharing her expertise tonight, and any information or questions pertaining to individual concerns should be discussed with your doctor. It is with my great pleasure that we have Dr. Elena Ratner, a board-certified gynecologic oncologist with special interests in chemotherapy-targeted drug development, patient quality of life programs, and early cancer detection. Her long list of credentials include Associate Professor of Obstetrics, Gynecology and Reproductive Sciences at Yale New Haven School of Medicine, Clinical Division Director, Section of Gynecologic Oncology at Yale Cancer Center, Director and Founder of the Sexuality and Intimacy and Menopause Program, and the Director of Discovery to Cure. Thank you, Dr. Ratner, for sharing your time and expertise tonight.
Great. Thank you, Robin. Thank you for this opportunity. I'm so excited that we are all on this call today. I'm very excited to share this talk with you, and hopefully we can make this interactive and beneficial for all of us. So what I would like to talk with you today about how the paradigm of ovarian cancer has changed and how it is certainly likely to continue changing and improving. So we're going to talk about a personalized approach to management of ovarian cancer, and we will save some time to talk about quality of life and issues of sexuality and intimacy. So ovarian cancer, unfortunately, continues to be prevalent and to, unfortunately, be deadly. 22,000 women get diagnosed, 14,000 women lose their fight. And among cancers for women, it is not towards the top, but it is so important because of how difficult this cancer continues to be. And that is why so much research is dedicated to this cancer to try to find its cure. The reason for why this cancer continues to be so challenging is multifold. Towards the end of the talk, or towards the middle of the talk, we will talk about difficult mechanisms of this cancer and how this cancer, unfortunately, is really smart and learns how to resist the therapy that we try to kill it with, and what we now do to be able to arm ourselves against it. But it's also very challenging because these cancers continue to be diagnosed at later stages. We used to say that ovarian cancer is a cancer that whispers, that there's no symptoms, and that is why most women still unfortunately get diagnosed in later stages. There's some new literature now that talks about how long these cancers have been present prior to diagnosis, as long as 18 to 24 months, and that women unfortunately see multiple providers before they are actually and finally diagnosed appropriately. So because of that, and because of that delay in diagnosis, and because the symptoms are so vague, these cancers still are diagnosed at late stage. But we know now that that's actually not necessarily the truth. Ovarian cancers do not necessarily whisper. It's that nobody is listening. Some very good studies by Barbara Goff show that, of course, great majority of women with stage 3 and 4 cancers had symptoms as high as 97%, but as high as 89% of these women had symptoms in stage 1 and 2. But these symptoms were so vague that women and, more importantly, their providers attributed them to hormonal changes, and those symptoms were not addressed earlier. What separates the symptoms that women get who subsequently develop ovarian cancer versus those who are just normal hormonal symptoms of menopause or perimenopause is that the symptoms that women get happen every single day for 2 weeks. And for those women who have hormonal changes and hormonal symptoms, those symptoms come and go. So much of what is being done right now in ovarian cancer research and prevention has to do with education and awareness and advocacy, and we are educating women to listen to their bodies, to pay attention to their symptoms, and when they do feel like they have symptoms or when they do feel that something is not right, to demand the care that they deserve and not to take no as an answer and not to not be listened to. And so much of what we do is educating the providers about identifying the symptoms and diagnosing these cancers early, because most of these women at the beginning of their presentation actually do not go to the gynecologist. Instead, they go to urologists and gastroenterologists and even chiropractors. So those are all the providers that need to be educated about the symptoms, because that is so important. So for women who do develop ovarian cancer, who are these women? In the older days, a couple of years back, we used to say that, a very small percentage, maybe 10% or so of these cancers are genetic or hereditary, and then great majority of them are something called spontaneous, which means there's no predisposition in the genes. We now know that that number is high. Women with BRCA mutation and women with Lynch syndrome, as well as some other genetic syndromes, have a higher risk of developing these cancers. But yes, overall, most women who develop it do not have a gene that predisposes them to this cancer. And the lifetime risk of getting ovarian cancer is approximately 1.4%. That number, of course, is higher for women who have genetic mutations. So the risk factors for ovarian cancer is older age. Average age of diagnosis is 63. Women who have never been pregnant, women who had infertility, BMI more than 30, and personal history of breast cancer. And things that are protective is having a tubal ligation. Nowadays there's actually a lot of thought and a lot of literature that a lot of ovarian cancers are actually not ovarian cancers at all. Indeed, they are fallopian tube cancers. So in my institution, we no longer do tubal ligation if somebody doesn't want to have children. Instead, we take out their tubes entirely. And taking out tubes is something that we do now routinely for women who are at higher risk to decrease their risk of ovarian cancer. Women who had hysterectomy, women who had multiple pregnancies, anybody who has had 5 children and breastfed each child for 1 year has a 50% reduction in ovarian cancer. And more practically speaking, is birth control pills. Birth control pills significantly reduce the risk of ovarian cancer. Anybody who takes birth control pills for 5 years decreases their risk by 50%. Anybody who takes it for 10 years decreases it for as high as 80%. So the reduction in risk is significant. And that goes for women who have genetic predisposition as well, such as BRCA mutation. And that reduction in risk is proportional. So let's say somebody has a 20% chance of developing ovarian cancer, but they take birth control pills for 5 years, their risk becomes 5 years, or but down by 50%. Big advice that I always give to everybody, not just patients and not just their families, but all my friends and girlfriends, is that at some point during your lifetime, try to get in 5 years of birth control pills to decrease your risk of ovarian cancer. So how is ovarian cancer treated? Right now, the paradigm continues to be such that treatment for ovarian cancer is a combination of surgery and chemotherapy. And there's many different ways of doing that treatment, and there's different order of the treatment. Sometimes we do surgery first, sometimes we do chemotherapy first. The goal of the surgery and the chemotherapy is to leave nothing behind at the time of surgery. So anything that has to be done for that has to be accomplished, and that's why frequently we would give chemotherapy before surgery to increase the chance of leaving nothing behind during surgery, and also to decrease the chance of having a very big surgery with a hard recovery. So it is very common to give some chemotherapy before the surgery to melt away a lot of the tumor, and then surgically remove everything possible. So the goal of surgery is to remove all visible disease. And surgeries nowadays are done both laparoscopically or robotically, and also through the normal old-fashioned way. And the benefit of the old-fashioned way is that we're able to use our fingertips to be able to feel the nodules. And the benefit of laparoscopic or robotic surgery, which I do quite a bit, is to shorten the recovery time and to allow women to get back to their normal lives and to be able to get back to chemotherapy. So either way that this is done is acceptable as long as all tumor that could be seen or could be felt is removed. In the older days, we used to talk about that when we do surgery, we want to leave behind nothing more than a centimeter. Nowadays, that number is 0 millimeters. We now want absolutely nothing left behind. And then following the surgery, women would get more chemotherapy, and that chemotherapy could be both intraperitoneal or intravenous. And there's multiple different ways, and we will talk about that in a few minutes, how chemotherapy is so drastically changing, how a couple of years back everybody would get the same chemotherapy, but nowadays the paradigm is such that we are able to truly provide personalized therapy, personalized care according to the mutations that the women have. Not as important what kind of cancer they have, but more importantly, what kind of mutations. Some of the recent literature says that women with ovarian cancer do much better if they are taken care of by specialists in this field, by gynecologic oncologists and providers and facilities that have high volume, that these women have a better prognosis and better outcomes. And that's, of course, not surprising. So the benefit of leaving nothing behind during surgery is very important. It has to do with the thought that the certain cells in these tumors that are called stem cells, and stem cells cannot easily be killed by chemotherapy. That's why those kind of cells, and we call them general cells or cells that are very difficult to destroy, can only be removed with surgery. And that's why surgical debulking or surgical removal of tumor is so important. So the way that this usually works is that women have symptoms, they get diagnosed, they get chemotherapy followed by surgery or surgery followed by chemotherapy. And in the older days, we would just finish the treatment and then wait and watch and check either CAT scans or blood tumor markers every 3 to 6 months to watch to see if the cancer cells would come back. Nowadays, some of the thoughts are changing, and one of the greatest advances over the past couple of years has been maintenance therapy. And maintenance therapy is using some sort of treatment when there is no active cancer cell present. And we'll talk about that in a few minutes. We do know that, unfortunately, even though most ovarian cancers respond really well to chemotherapy up front, the majority of them do come back. And when they come back, we just continue treating them as we are and stabilizing them and giving more vacation time in between chemotherapies, but then coming back to the chemotherapy after that. So that's why it is so important to try to extend the period of time in between chemotherapies, something that we call progression-free survival, which means that the woman would not be on active therapy, but would be on something that would be much more easily tolerated. So much research has been done to try to find a way to extend that period of time. So we have done research in ovarian cancer for a very, very long time. And you can see this is the summary of some of the key research advances in the field of ovarian cancer. And you probably see many drugs on this that you're familiar with. But more importantly, you can see that from 1960s to mid-2014, 15, there really has not been great advances in ovarian cancer, and not for the lack of trying, but just because of the complexity of the cancer. In particular, a lot of research over the years has been dedicated to trying to find an effective and easily tolerable way to find this maintenance therapy, to find a way to extend the period of time between active chemotherapies. And we have looked at many things. We have looked at antibodies and injections and pills, but unfortunately, until recently, we have never been able to find anything that was effective. And that is why what happened in 2017, 2016 is so exciting. So a few things happened. In 2014, first of all, there was a drug called olaparib or Lynparza, which was the first PARP inhibitor that came on the market. And olaparib was a perfect example of a personalized targeted therapy that was specifically for women with BRCA mutation. Around the same time, chemotherapy with addition of bevacizumab or Avastin also came on the market. And again, it was exceedingly exciting because it was not cytotoxic chemotherapy. It didn't have too many side effects, and it worked on the blood vessel. And additional bevacizumab appeared to prolong progression-free survival as well. In the next couple of years, other PARP inhibitors came on the market, niraparib and rucaparib. So as I was saying, then in 2014, olaparib, Lynparza came out on the market, and it was incredibly exciting drug. It was incredibly exciting concept of using targeted personalized therapy specifically for women with BRCA mutation. And it was incredibly exciting, but it was at the time only for a small category of women who had the BRCA mutations. And as I mentioned to you before, that proportion of population is at the most 15%. So what followed next was even more exciting. Multiple other PARP inhibitors came on the market, niraparib and rucaparib. And what made them so exciting, not only that they also had incredibly positive results, but that they weren't just for women with BRCA mutations, they were for all comers. And I'll talk in a few minutes about what that implies. In case you did not hear me, I will repeat also that around the same time, bevacizumab or Avastin came on the market, and that also was a very exciting advance because similarly, it was not cytotoxic chemotherapy, but it was a special medicine that worked on blood vessels that showed to improve this progression-free survival. So overall, as you can see, not many things happened for many decades, but then starting in 2014, some really, really exciting things that happened. And I'm going to show you exactly what. So the complexity of ovarian cancer is such that it is a very complex field. You know, there's many different ways that these cancers learn how to resist therapy. And, 5 years ago, 7 years ago, I used to give this talk, and I used to show you these aspects and tell you that ovarian cancer is so complex because of these genetic and cellular and molecular levels. And it's complex as to what turns on and turns off the controls of this cancer. And I will show you this graph, and I would say, this is why it's so hard. This is why we're struggling with finding cures and treatments, because there's so many different aspects of this cancer that we need to take into account. But this is now the new slide, and this is something that is not totally established, and we're still in the infancy, but it is incredibly exciting that out of the challenges of this cancer, out of the challenges of the resistance and the complex mechanisms, comes opportunity to attack this cancer better and smarter. So for all these challenges and limitations of complex mechanism, we now have a way to be able to target them, to hit them, to kill them in a much more specific and much more targeted way. So you see the PARP inhibitors, this is what I was talking about before, the work on DNA repair and VEGF signaling that I mentioned to you before with bevacizumab, as well as many, many other different targets that we now use. And when I give this talk to you in a couple of years, this graph is going to be way more complex and way more busy because half of those things we did not have a year ago. And that is how exciting and how fast this field is moving at this time. So nowadays, the way that we treat this cancer, it is much less about the type of cancer, but it's more importantly about specific functions of the cell. So sometimes we treat ovarian cancer how I would treat thyroid cancer or how I would treat melanoma. Because at this day and age, I care much less about what kind of cancer this happens to be, but I care more about what kind of mechanisms and what kind of ways this cancer, what kind of weaknesses this cancer have that I can attack. And this is many different ways of opportunity for us to use different targets, this one in particularly for the PARP inhibitors. So bevacizumab, is what I mentioned to you before, is a great advance. It is used for first-line ovarian cancer treatment and maintenance, and also is very active and successful in recurrent disease. I use it a great deal in my practice, and some of my women on bevacizumab for 3 to 5 years during their treatment. This is now all the literature that came out over the past couple of years to show you the great advances, in particularly of bevacizumab and of PARP inhibitors in the maintenance setting in this patient. And the results were quite astounding. The results of these PARP inhibitors was unlike anything that we have ever seen before. What these studies have shown that using PARP inhibitors in women with BRCA mutations showed incredible benefits. So 21 months versus 5 months when women were not on PARP inhibitors. And this wasn't benefit just for women. It wasn't just for the women who had BRCA that was hereditary, that was genetic, that was in their blood, but it was also for women who had normal BRCA in their blood and they genetically did not carry the mutation and genetically did not pass it on to their children, but had BRCA mutation in their tumors. And that number is actually much higher than the 15% that I told you before of the women who have the germline mutations. And we now routinely, every single one of my women who has ovarian cancer gets not only their blood tested for this mutation, but more importantly has their tumor tested for this mutation, because I know that maybe additional 20% will have additional mutations, and I will know that they will benefit from these drugs. But even in addition to PARP inhibitors, I look for 380 mutations in the tumors, so I know how to attack them better and smarter. But so unquestionably, we know that for women who have BRCA mutations, again, whether it's germline or just in the tumor, the benefit of PARP inhibitors is really astounding. It's with numbers that we have not seen before, as you see here again in the 20 months. But what about women who do not have the BRCA mutation? Because even if we say that maybe 30% have it, still 70% of women do not. So these are different studies. This is different studies that look at different PARP inhibitors, and this is kind of how these studies are a bit different. But essentially, I'm just showing you that some of these studies were for women who just had the BRCA mutations, and other studies were much more open. They were for all comers. They were for women who had the BRCA mutations and those who did not. And it shows that for women who had the BRCA mutation, they had benefit that was very profound. Again, like I mentioned to you before, 20 months versus 5 months. But even for women who did not have the BRCA mutation, which again are the women that we did not know whether they would respond or not, you can see, so those women also had a substantial benefit of longer than 9 months versus 3.9 months in those who did not take this drug. And what's even more important, is two things. One is that now we are so much smarter that we are able to really look at the tumor and study the tumor and understand the genetic makeup of these tumors and understand who is likely to respond to these medicines and who is likely not. So I'm able to study the tumor and understand whether the mechanisms of DNA repair are such that these women are likely to respond or not. So it's truly personalized and individualized treatment. But also, very importantly, you can see that even for women that did not have any mutations, for whom I would not have expected the response to be very good or very long, 20% of these women still had no cancer at 24 months. And you can, and in the better group, 31% of these women. So not only do these new drugs work and are efficient, but as important, and even more important, that for some of these women, and this is a nice percentage, it's 1/3 or one fifth, that of these women, this response is not just profound, but also long-lived, and they benefit from these drugs for many months and many years. So that is quite incredible. So, and this is just some of the many examples of these new targeted therapies. And again, it all stems from being able to check the tumor, study the tumor, understand the tumor, and then being able to offer these multiple new targeted therapies in a very personalized way. So the way that this is done in my institution is, again, we very much believe in this personalized medicine because cancer is a genetic disease and specific targeted treatments are needed. So personalized medicine allows for the tailoring of the medical treatment to the individual characteristic of the patient. And the benefit of that is not only will the therapy work better, but also the side effects will be less and women are able to live their lives easier and better while we are controlling their cancers in a personalized, individual way. So this is how it's done in my institution. Like I mentioned, during surgery, we take a piece of tumor, we study the tumor, we'll look at 380 mutations inside the tumor, and then in our labs, we establish the cell line for these tumors. And for tumors that are hard to treat and complex, we put them into mice. And then we treat these mice with therapies, and for the therapies that benefit the mouse, we then bring it over to the patient so it benefits her. Additionally, we are looking at cells, circulating tumor DNA cells in the blood that tells us whether the tumor inside is dying or is still alive. So that's just some of the examples of this new personalized approach, which is very much changing the course and the nature of this disease. So in conclusion for this part, ovarian cancer continues to be difficult. We have to be diligent. We have to be aware. We have to talk to each other. We have to be advocates for this disease and make women aware of the early symptoms and empower these women to demand and receive the care that they need and that they demand for these cancers to be diagnosed early. Truly personalized approach is needed and is upcoming and is exciting and is changing the nature of this disease. And this extends to surgical care and therapy. We now are able to do very complex, very big surgeries laparoscopically, and when in the older days, the patient would be in the hospital 7 to 10 days. Now they go home same day or next morning. That is changing the nature of the disease. And now, more importantly, treatments that we cannot treat all cancers the same. We have to be smart. We have to be proactive. We need to study these tumors. We need to understand them. These tumors are smart and complex, and we need to be the same. We need to use this complexity of the tumor not as a challenge, but as an opportunity to target this disease and target these cancers, not only to make it work better and improve the efficacy of our treatments, but as important to provide good quality of life and to provide the way for women to live their lives relatively uninterrupted. So, and I gave you the example of PARP inhibitors and immunotherapy and BEVAVIZUMAB as examples of these new targeted approaches, of which there are many. I'm going to talk briefly now about quality of life. As you can tell from my talk, quality of life, I believe quality of life to be extremely important. Ovarian cancer very much is, and becoming even more so, a chronic disease with which women live for many, many years, and it becomes like diabetes or heart disease. So it is very important that we not only concentrate on early detection and cure of these cancers, but that we concentrate on quality of life and optimizing everything that we can. So sexuality, intimacy, and menopause is something that women with ovarian cancer very frequently suffer from. It has to do with many aspects, a lot of them having to do with the cancer itself, with the treatment itself, with the surgery itself, and hence this is a very common side effect of the treatment. There's many, many cancer survivors, and that number is expected to grow exponentially. 1/3 of all men and women who live today will be diagnosed with some sort of cancer during their lifetime. A lot of these cancers are curable, and a lot of these cancers, there's many survivors, and that is why we need to know how to deal with the side effects. 65% of survivors have cancers that affect sexual organs, and ovarian cancer certainly is one of those. Females suffer with this a little bit more than males. For women, the distress of these concerns grows longer, grows higher as they have more acute distress, so women are very affected by this. And we know, we used to think that breast cancer was the cancer most affected by these symptoms, but we now know that gynecologic cancer is even more so. I'm not going to go too much of the definitions, but there's very specific definitions of the sexual dysfunction: pain during sexual intercourse, hypoactive sexual disorder, orgasmic disorder, sexual pain disorder, and they are kind of self-explanatory. So hypoactive sexual desire is having very little desire for intercourse, sexual arousal, inability for arousal, and orgasmic disorder, inability to have an orgasm. And then sexual pain disorder, which is very, very common, is pain during intercourse. The prevalence of this is very high. This is not for women and men with cancer. This is for general population. So there was a very big study of 40 million American women. There was a very big study of all the adults in the U.S., ages 18 to 59, and from the study we found out that 40 million of American women were affected by some sort of sexuality dysfunction that affects women more than men, 43% to 31%. And then increases as women age, and for men it stays exactly the same. And you can imagine that the number is so high for general population, that number is higher for women and men with cancer. And the numbers of the dysfunction really spread themselves equally. So 43%, 32% had lack of sexual interest, 28% unable to achieve orgasm, and 21% pain during intercourse. So for men and women with cancer, that number is much higher. That number is as high as 80% for women with breast and gynecologic cancers and 90% of men with prostate cancer. And the causes are very complex. that includes both physiologic and psychologic. So I want to stop for a second at this slide because I think this slide is one of the more important slides of this talk, just to show you how common sexual dysfunction or intimacy dysfunction is in gynecologic cancers. It's complex, and there's many different reasons for this, but it is talked about so little in this field that I think many times women don't appreciate how common this is. And again, in my practice, this is just commonly addressed and discussed, and it's part of our normal exam and normal questionnaire because we know how common it is, and that helps us open up that conversation. So just very briefly, because there's such a big part of the psychologic aspect of the sexuality and intimacy, it's just one quick word about this very important model called the Bassan model. Prior to Rosemary and Bassan, the model of female sexuality was very similar to the model of male sexuality. We used to say that it was similar, it was excitement, plateau, orgasm, and resolution. And, there's a couple of other different attempts at this that really just equated female sexual cycle to the male. But Rosemary and Bassan had a most beautiful model that showed that for women, sexual intimacy and and sexuality actually has to do much more with emotional intimacy than it does with actual steps of the sexual act. And she showed that for women, there was many different ways to increase sexuality, but all of them really had to do with increasing intimacy. And the few things for women that actually improved their desire to be with their partner was either having a new partner or when their partner was away for longer than 2 weeks. So those were the two things that predisposed women for being more sexual towards their partners as a model, which I think is actually very, very interesting and very funny. So in women with cancer, there's many different aspects that predispose them to this difficulty and this dysfunction. And it has to do with cancer. It has to do with treatments such as surgery, radiation, chemotherapy. Women with breast cancer suffer a great deal with this because of their hormone management, as well as because of the surgeries that they have had that change their bodies and make them feel different and frequently make them feel like they lost their femininity and makes it more difficult. This was the study that discussed with that. So from the sexuality perspective, we got to address this from different aspects. Women with gynecologic cancers have had surgery, and that certainly contributes to their hormonal status. That hormonal lack of estrogen contributes to decrease in sex drive. It contributes to pain with intercourse. What they have gone through the cancer diagnosis and through the treatment also contributes greatly to the psychologic aspects of their cancer. And this relationship is very complex. Age plays a large role, menopause, symptoms of menopause, quality of life, and sexuality. And these five are very much intertwined and really kind of have to be addressed all at once. And some of these symptoms are easy or relatively easy to manage. Having vaginal dryness is a very common symptom under those circumstances, and that is usually very easily manageable with either herbal medicines, but also with hormonal management, which is very safe because for vaginal estrogen, very small amount actually gets absorbed. Systemic symptoms are more difficult. Things like hot flashes, things like difficulty in sex drive, difficulty concentrating, poor sleep, those are much more difficult. And systemic hormones are a little bit more difficult discussion where we really need to discuss pluses and minuses, benefits and risks of it. many different medicines and medical conditions contribute to this, and those have to be addressed very carefully when diagnosis is being made. And then most importantly, treatment. What can be done? So psychologic counseling plays a very big role, both individual, couples and groups. Medical, which includes hormone treatment, medications, medical devices, and surgery. And the approach that I argue for, which is the integrated medical and psychological approach, and that is the approach that we use in my institution. I will skip through these because there's a little bit more detail of those, but in summary of all these symptoms, vaginal discomfort and pain are the most common symptoms that women experience with cancer diagnosis. And as I mentioned, there's a lot of lubricants that can be used. There's vaginal estrogen that can be used. There is herbal medicines that can be used. Things for sex drive, which is testosterone, can be used, especially if the cancers do not have hormone receptors. And we use testosterone as well as estrogen for the sex drive. Interestingly, women can use Viagra, just like men use Viagra, and that particularly benefits women who have diabetes and also who have cervical cancer, for whom nerves are not, nerves of the clitoris are somehow damaged or not as functioning. And also for the women for cervical cancers who had big surgeries, there's many different mechanical devices that can be used to try to improve orgasms and try to improve their response. But most importantly, and this is just the pain options that I was discussing with you before, which is vaginal estrogen, which is safe, but systemic estrogen, which has more potential side effects and really has to be considered after other entities are exhausted. But in overview of this, the most important point that I wanted to share with you before is how important quality of life is, and what a big role sexuality and intimacy plays in this, and also how absolutely common and prevalent it is. And many of the discussions that I have with my women and my patients is really just acknowledging that this is all part of the normal course of this cancer and the treatment, and it is incredibly common, but should not be accepted as the norm. And we always try to think of specific issues that can be targeted. And I would encourage you to do exactly the same with your providers. If there's something in particular that you feel could be optimized, it certainly can and should be, and this should be very much part of the normal treatment and optimization that you go through for your treatment. So I'm going to save some questions, some time for questions. We have 50 minutes, so I'm going to pause here.
Thank you so much, Dr. Ratner. That was terrific. Dr. Ratner, is Lynparza the best drug for BRCA2 ovarian cancer? I've been on it for 6 months now. If so, I'm interested in what superfoods work well with it. Besides grapefruit, what should I avoid? And any other significant findings related to Lynparza in terms of what to do, what not to do?
Sure. So Lynparza is a wonderful drug. That was the drug I showed you before, the olaparib. That's the drug that's the strongest for women with BRCA mutation, or the literature is the strongest. But yes, all these PARP inhibitors are actually very similar in terms of how they work. They all have very similar efficacy, which is great, because if you're not tolerating one drug, then you can have a sister drug or cousin drug that also will work very well, but will give you different side effect profiles. So if you're on the olaparib for 6 months, it's wonderful news. That means you're tolerating it, and it means that it's working. And yes, this is a wonderful, wonderful drug for BRCA2 mutation. In terms of food, it's a question for the ages. There's a lot of older thought about sugars and avoiding that. The current thought really is that it's very, very important to eat well. and exercise, and that is more important than anything. And I always tell my patients, do not, if you really like sweets and you need to have a piece of chocolate in the evening time, do not let yourself not have it. There's absolutely no literature that is so absolute. That it's more important to eat well and exercise and have a good functional status, and that has been very much connected to better prognosis.
Okay, thank you. Another question in the chat is, can you discuss T-cell trials and Notch1 and TP53 repair research?
Yeah, so this is part of this new approach, which is targeted therapies. And this was part of what I showed you on the graph a couple slides back. Yes, this all has to do with targeted therapies. It's not for everybody. Similarly, the tumors have to be studied, and they have to be appropriate mutations. But if those mutations exist, then yes, this is a great new approach of targeting these cells and have your immune system fight the cancers. And there's some positive preliminary data, but only in women who have specific targeted mutations.
Dr. Ratner, I finished chemotherapy 5 weeks ago. It was dose dense for 18 weeks, every week, and my doctor talked about putting me on Lynparza, but I don't have a BRCA mutation. 2 other mutations were discovered in my tumor, and I don't have the paperwork with me, so I really don't know what they are. I don't remember what kind they are, except that they had to do with methylation. My doctor has told me that there's a conference at the end of this month in Barcelona, the European So you know about that conference.
Of course.
Do you know, and have you heard anything about the results that are going to be discussed there in terms of Lynparza for non-BRCA women? That's what my doctor is waiting for.
Yeah, so the question's a bit more complex. Yes, I'm very involved with that literature. No, of course I don't know, or I wouldn't be able to tell you what that's going to be said. This is our big conference that comes up in the next couple of weeks, and there's going to be a lot of very important information that's going to come out. You must have one of the mutations that you must have must be the BRCA mutation that I was mentioning before in the tumor, but your doctor would not have been able to offer you olaparib if you did not have that kind of mutation. But what's going to come out in ESMO in Europe is something called results of the PRIMA study. This is going to be very, very important results. It's going to talk about benefits of PARP inhibitors in women who do not have BRCA mutations after they complete chemotherapy. So yes, this is the study we're all very much waiting for. The literature for use of olaparib or pretty much any PARP inhibitor in the adjuvant setting, so after you finish chemotherapy, if you have the BRCA mutation, are astoundingly positive, really, really wonderful results. So now we are eagerly waiting to see the results of the PRIMA study to see if that benefit also is similar for women without BRCA mutations. So yes, in a couple of weeks we will know that information.
Okay, thank you.
We have another question in the chat. Why do drugs such as PARP inhibitors eventually stop being effective?
Oh, that's a wonderful question. So it has to do with that complex thing I showed you before, how ovarian cancer is unfortunately so smart that they learn how to resist chemotherapy or PARP inhibitors. So similarly to how, chemotherapies only work for a period of time, and then the tumors learn how to resist them by different alternation in their mechanisms. Similarly, they learn the same kind of mechanism, resistance to PARP inhibitors. So there's something called DNA repair. This is how they work. It's called homologous recombination. And the cells, unfortunately, learn how to resist it. But that's not to say that we're not thinking of the next step. Right now there's a lot of research as to what can be done and what should be done to try to reverse that resistance. And, a lot of labs, including my lab, we are doing research on trying to reverse that resistance and finding a way to give women who are no longer sensitive to PARP inhibitors in combination with another drug, which will essentially reverse that resistance.
Someone is asking that she has a recurrence of granulosa cell tumor. How do I know if my doctor has tested my tumor for important mutations? Her tumor was sent to Foundation 1.
So that's an excellent question. So granulosa tumor is a bit different from everything else we talked about today. So kind of take everything that we discussed with a grain of salt because it's a little bit different mechanism and different everything. But yes, if your physician sends it to Foundation 1, then she has the information she needs. Foundation 1 is what you need to genomically subtype the tumor. So that would be sufficient.
Okay, thank you. More questions, folks?
I have a question.
Go ahead.
In talking about recurrences and genetic Foundation 1 testing, doesn't the tumor profile change from recurrence to recurrence?
Yes, absolutely. So another excellent question. Yes, the tumors change with time, and like we mentioned before, they become resistant. So yes, recurrence to recurrence, these tumors change. Usually not one recurrence to the very next recurrence, but overall, yes. So it is usually a few times that I would say check the genomic foundation for these tumors during the course of treatment, because the tumors, 3, 4, 5 years out from the original diagnosis are very different indeed from the tumors that we study at diagnosis.
Okay, I have a second part to that. What if there is a recurrence but not enough to biopsy to test for a mutation or a change in the makeup?
Oh, another excellent question. And that happens. And, I certainly don't recommend biopsying it a lot at all, because biopsy is now without side effects. If the tumor is too small to biopsy it, I just wouldn't do it. I would just treat and look at the C125 and look at the CAT scans and let that be determination whether the drug is working and whether the tumor is different. Only if tumor is big enough or if it's not responding, that would be my cue to actually, again, do the genomic testing. But I wouldn't do it if it's too small to biopsy.
Thank you.
Mm-hmm.
Okay, we have a question in the chat. Does the literature also suggest that Lynparza works to prevent breast cancer from showing up?
Mm-hmm.
Yes, I see that question. So if a woman has BRCA mutation, then yes, and the BRCA mutation is not just in the tumor, but in her blood and something called germline, so through all her tissues, then yes, conceptually, it also, even though there's no indication right now for use in breast cancer, but yes, conceptually, it would also work on that. But I'm hesitant to say because there's really no evidence-based studies on medicine for me to really quote it. But conceptually speaking, I think that's the right idea. I just don't, there's no literature to support it.
Okay, thank you. More questions, folks? Okay, we have a question in the chat. If you have chemotherapy before surgery, can you still get information from the pathology to individualize your treatment?
Wonderful question, and I'm sorry I didn't mention it before. So yes, some of the mutations are not altered by chemotherapy. So things like BRCA, things like homologous recombination, things like PD-L1 or MSI, things that make you candidates for PARP inhibitors for immunotherapy are not altered by previous chemotherapy. Certain things are, but not anything that's clinically pertinent to choose the drug. It's an excellent question.
I was positive for a BRCA gene, and my daughter was tested, and she also is positive, although she has had no disease at all. They are watching her carefully, but does she need to be treated with Lynparza, or do they need to be particularly sensitive when my daughter goes for her testings?
Oh, yes, so definitely not Lynparza. Please do not let me confuse you.
Okay.
I'm talking with PARP inhibitors, Lynparza, one of them. I'm only talking about treatment of cancer. There's absolutely no literature for using any of these drugs as preventative drugs. But your daughter does need to be seen by specific physicians who have expertise in this. Depending on what kind of BRCA mutation it is, they have to provide her with a specific personalized plan of surveillance, whether it's ultrasounds, whether it's blood tests. And usually when she's done with childbearing, depending again on what kind of BRCA it is, we do recommend that either fallopian tubes or fallopian tubes and ovaries are removed to decrease this. But that doesn't usually happen until 35 to 40 years of age, again, depending on what kind of BRCA mutation it is. So, yes, she needs to be seen by specialists. She needs to be seen by people who understand what this mutation entails. And then it would be, again, a very specific, personalized, individualized plan according to her mutation, her age, and her life circumstances.
Okay, thank you. All that is being done. I just wondered if there was more, but she's seen very extensively.
Good. That's great.
Okay, folks, this concludes our webinar tonight. And Dr. Ratner, I want to thank you so much for your passion, dedication, and commitment to the ovarian cancer community, and to all of you for coming out tonight and taking the time to become educated on this very important topic. Have a great night, everyone.
You too. Thank you.
Thank you.